for this afternoon. I have the share. Can Prof Kuan, perhaps you can share your screen where
Yes,
Professor Dr.
Can you
Kuan.
hear me?
Yes, I can hear you loud and clear.
Okay.
Maybe you try to share your screen.
Sure.
Before you start, you just share the screen. I just want to check technically it's okay. Okay, I think you are sharing. Good. So you can just open the presenter mode. And let me introduce Professor Kuan. Professor Dr. Kuan is a hematologist. Is also my teacher, our consultant hematologist. He graduated from University Malaya, and she obtained the MRCP in 2005, and has a vast interest in hematology, and has been also conferred PhD by Japan University in 2020. She has many publications and a lot of grants in relations to hematology topics. And I think a lot of us know AMPAM protocol when we are housemen and medical officers, when we attach to a hemato department, and she is one of the protocol author for the AMPAM protocol. So with that, I pass the time to Professor Dr. Kuan for her talk this afternoon.
Thank you, Dr. Ling, for your kind introduction. I just would like to check my voice. Is it clear? Okay, good. So I will proceed. Okay, good afternoon, everyone. Okay, it is my pleasure to give you a lecture on identifying hematological patients who can turn critical suddenly. In my opinion, this lecture title is a little misleading because it seems to only focus on patients who have been diagnosed with hematological disorder. But in your real life in district hospital, the patients who can turn critical suddenly and present to you in district hospital are usually the undiagnosed or new patients. So actually, in this lecture, I will concentrate more on the new or undiagnosed case. But of course, I will also mention on the patient who has been diagnosed with hematological disorders. So pardon me on the title. So I still keep it because I think this title will surely show everyone that it is about hematology. So let's go to the content of this lecture. So first, I will mention about the mechanisms that can turn hematological patients into critical state suddenly. Then I will mention the selected hematological disorders that cause the above mechanisms. Then I will mention the primary prevention, which I think will be of your interest, because if you done this primary prevention, it will reduce the chance that you bump into this kind of critical state during your on-call time. You will have a more peaceful life, and the nurse will not ask you to mandi bunga. Okay, so and then then I will go to the type of cases, the new and also the non-case. Then I will finish with the universal management of the hematology of hematological patients. Okay. Maybe can I check whether you can see my cursor or not?
Yes.
Can see, Okay, good. Okay. So the mechanisms that can turn the hematological patients into critical states suddenly are usually these three. So thrombosis, bleeding, and shock. You might think in your heart that these three. Okay, so all the other disciplines like cardiology, the patient can also present with these these mechanisms, and that in critical state suddenly. Okay, maybe I give an example. The patient that present with MI, acute myocardial infarction, so the patient can have thrombosis. The thrombosis, then the patient can go into the cardiogenic shock. Then later, maybe after your thrombolysis, the patient might develop some bleeding. Okay, so that's for the other discipline. However, I would like to emphasize that hematology is different. Okay, because there are some hematological patients that can present with both the three mechanisms at one time. Thrombosis together with bleeding, because usually thrombosis and bleeding will not come together. Okay, unlike the one that just now I mentioned in the myocardial infarction, actually it is not coming together. It is one followed by the other. But in hematology, there are conditions that the patient can come with both thrombosis and bleeding at the same time together with this shock. So you can imagine it is very, very messy. And 2 of the 4 hematological conditions that can present with thrombosis and bleeding will be mentioned in this lecture, whereby 1 of the 2 is here that I mentioned here. Okay, TTP, thrombotic thrombocytopenic purpura. The other selected hematological disorders that can cause a big three are listed here. Allow me some time. Maybe I mention through the disease the 6th category of diseases here for the benefit of some of the audience. So leukemia, I think there's no doubt everyone will know. Lymphoma, no doubt everyone will know. Myeloma will know. So for myeloproliferative neoplasms, it is a kind of blood tumor. It is not really cancerous yet, but it can turn into cancerous later. But in this condition, the patient will have increased blood count in either 1 or 2 of the cell line, either it's a red blood cell, white blood cell, or the platelet. Whereby for the myelodysplastic syndrome, this is a category of the disease whereby the bone marrow is still working, and it's actually usually overworking, like in the myeloproliferative neoplasm. But the overworking is because the bone marrow is already dysfunction, because they have some underlying genetic abnormality, and they try to overcome this by producing more cell. But at the end, actually the patient ended up with cytopenia because most of the cells that produce are defective. So the patient actually comes with cytopenia for this myelodysplastic syndrome. So TTP is a very dangerous disease that it is actually a hematological disease emergency. TTP in adult, it is usually autoimmune related due to autoantibody that produce against an enzyme in our body called ADAMS 13. So because of that, then your platelet in the body cannot be cleaved down into a normal small size platelet. So all the platelets will be big because lack of that protein, and lack of that protein, sorry, not the platelet, the warm virulence factor will be very big because it cannot be cleaved down into a small fragment. So then the patient will become coagulable due to this high multimer warm virulence factor. Okay, and it can cause thrombosis. At the meantime, because of the consumption of the platelet, the patient will have thrombocytopenia, which leads to bleeding, and of course it can lead to shock. Okay, severe aplastic anemia is basically bone marrow failure. The bone marrow fails to produce adequate blood cells to support our body, and it can be in the category of severe. So that's we call it severe aplastic anemia. I think I don't need to explain about ITP. I think everyone with ITP, but not all ITP are dangerous. Only a minority of them who presents with bleeding, that will be dangerous. Okay, so let's go to the primary prevention that I think what you all want to listen about. Actually, it's very simple. The primary prevention is the full blood count screening. The full blood count screening in the non-hematological patient. So you do full blood count screening. You don't have to do it very frequently. You can do maybe like once every few years, once a year, once every 2 years, or once every 3 years. But I think it would be better between once every 1 to 2 years. You do some sort of like full blood count screening in the patient that comes to you for regular follow-up, but who have not had any hematological disorder yet. This will be very helpful in targeting or early diagnosis of certain chronic blood disorders like myeloproliferative neoplasms, which can subcategorize into PV, ET, and CML, and some lymphoma, some more indolent lymphoma like follicular lymphoma, CLL, chronic lymphocytic leukemia, or the other name is small lymphocytic lymphoma. Small lymphocytic lymphoma. Another chronic blood cancer, myeloma. Actually, you can detect it earlier. So the chronic ITP, okay, and the MDS, MPN, when there are another subcategory of disease called myelofibrosis. If you do this, okay, so you have sort of like screen out this disease, this one, and also like the chronic ITP that can present with bleeding. It will reduce your chance to bump into this kind of problem and have a more peaceful life in your district hospital. Okay, so maybe I will go through on how to diagnose all these diseases in here, so that you got more better understanding. Okay. Oh, okay. So hyperviscosity. So hyperviscosity is the second hematological condition that can cause the full house of this. Okay, hyperviscosity syndrome means that the state of the the status of the patient when the patient presented with symptoms and signs that suggest the blood is very thick, very viscous. So the symptoms is mainly due to CNS and lungs, where usually the effect of hyperviscosity is more in the small blood vessels. So usually the patient will have symptoms due to CNS and lung, okay? And the patient can have headache, giddiness, the feeling of heavy headache, okay, lung, then you can then the patient can have dyspnea, okay? And then I know you all will not have any sophisticated investigation tests in district hospital. So the one that are very easy to the one that you can use to diagnose this condition easily will be the fundoscopy. So you look at the fundoscopy of the patient. So you see this dilated, tortuous, sausage-like, link-like retina vein, and then with sometimes accompanied by these hemorrhages here. From there, together with your full blood count result that shows high HB or platelet or WBC, then you already can diagnose the hyperviscosity syndrome, and then you make sure you prevent it, so that you give adequate hydration, so that the patient will not go into the critical state suddenly in the middle of the night. Okay. The myeloma. So then the other, like chronic ITP, you know that the patient, due to the thrombocytopenia, the patient can go into bleeding suddenly, then lead to hypovolemic shock. The other condition here that I listed down here is due to the anemia, leukocytopenia, or the thrombocytopenia. So these are the things that can lead to the two of the big three here. Okay, so by doing and which you can prevent it by doing a full blood count screening. Okay, so you might say the full blood count result that I have in the district hospital is it's very simple. I don't have the full blood count result like this, which consists of 30 plus parameters, or a full blood count like this consists of roughly about like 15 parameters. I only have this kind of full blood count whereby it will give you the total white cell, RBC, hemoglobin, the platelet, and then you can get some breakdown of like neutrophil and lymphocyte. I know in some of the district hospital, the report will not be neutrophil. There will be granulocyte, GRA. Okay, GRA. So that is already good enough. That is already good enough. Even you have not, if you don't have that, this is also this is also good enough. Okay, that will provide you with total white cell, hemoglobin, and also the platelet. It's already good enough. So don't be discouraged by the lack of facility in your hospital. Okay, so however, if you got the privilege of having the lab printing out the report of these differential count like neutrophil and also the lymphocyte here, don't forget to have a look at it. Because it will help you to diagnose certain diseases earlier, which is the some lymphoma, like follicular lymphoma and CLL, which will have a disproportionate neutrophil and lymphocyte count, whereby in normal adult, neutrophil is always higher than the lymphocyte. So neutrophil is roughly about half of your total white cell count. Lymphocyte is always less than neutrophils. But if you notice, this lymphocyte is quite higher than the neutrophil count, and the patient is asymptomatic, sitting in front of you, come for follow-up, let's say for hypertension and diabetes, keep your mind open. Okay. Maybe it's due to viral, okay, but just to follow up the patient by repeating full blood count, maybe in 4 months, 6 months time. If this persisted, if this disproportionate percentage persists, then please think of the lymphoma that I mentioned about, okay? Because usually in the early stage, the total white cell will not go up yet. It will comes with the disproportionate neutrophil and lymphocyte ratio. Okay. So for the new cases that present to you, okay, I know deep down in your heart or subconsciously, your wish is to refer and transfer to hematology ASAP. Okay, so you will need to know what condition will hemato take over step, and what condition will hemato take over as ASAP, and what condition will hemato take over early. Okay, but the one that take over step and ASAP, we know that they are high risk of getting these big three. Okay, so what are they? So the one that we will take over step. Okay, so if I don't have bed, I will still somehow squeeze a bed out for you all. Once you refer me, will be these two. A type APML, a type of acute myeloid leukemia called acute promyelocytic leukemia. Okay, and just now I mentioned about TTP. Okay, and what condition that hemato will take over as soon as possible, which is listed down here, whereby it's SVCO obstruction secondary to suspect lymphoma. SVB suspect lymphoma, because other cancer like lung cancer, it can also cause the SVCO. So you have to the patient have to be sound like it's a lymphoma, then definitely will take over ASAP. Then the patient that with hyperviscosity syndrome, the one that you just now I show you the picture of fundoscopy with the dilated tortuous retinal artery. Okay, so then you will know that. Okay, then this one will definitely take over. Okay, the patient that with acute leukemia, the patient that with severe aplastic anemia, and ITP with bleeding. So let me just talk further about how you diagnose this kind of disease condition or diseases in district hospital that with limited resources. All of this you can diagnose. Okay, you can diagnose. Okay, so for acute promyelocytic leukemia, typically the patient will have pancytopenia. Okay, but sometimes you can the total white is instead of low, it can be high or normal. But the typical one will be what we call a faggot cell on the peripheral blood film, whereby you can see a very big size of blood cell that you can see here compared to your normal neutrophil and lymphocyte. It is way big. You see, this is the size of the red blood cell. Okay, so this blood cells is at least four diameters of 3 diameters of the red blood cell, or four diameters of the red blood cells. Okay, and it is like the nucleus is like in the figure of 8 with a lot of nucleoli here, and then with very dirty kind of cytoplasm, and then you can see a rod-like structure, not only one but multiple in the cytoplasm. That is very, actually not very, actually is already enough to diagnose a PML. Okay, so you can diagnose it in peripheral hospital. Just ask the MLT to stand it for you, and if the MLT is inexperienced, you go down and have a look at yourself. If you see these things, okay, straight away you call, and then definitely we'll take over step. Okay. Just now for the TTP, beside the PANTAC will be fever, microangiopathic hemolytic anemia picture, thrombocytopenia. They can have renal impairment and CNS manifestation. And then when you do the peripheral blood film, you will see cystocyte, or another name is called fragmented red blood cell. It will look like this. Fragmented, the red blood cell is cut or chopped like that. Okay, so this will be the fragmented red blood cell, and typically the PT FPTT will be normal and the Coombs test would be negative. Okay, so with this is highly suggestive for TTP, and then you refer, and we will usually take over step, because these two are very dangerous. Okay, so very dangerous, and you can see TTP is full house. Just now the APML is mainly on the bleeding and shock, but sometimes it can cause thrombosis because it can cause DIC. Okay, so then we go to superior vena cava obstruction. Okay, the symptom and sign will be very typical. You can see this dilated vein on the chest wall. The patient will have facial swelling, periorbital swelling, and the swelling at the upper limb at various degrees. And the color will be more congested at the upper part of the body compared to the lower part of the body. And to convince a hemato to take over, okay, then you can you find not only lymph nodes at the cervical, then the chest X-ray that show enlarged mediastinal, then you can find lymph nodes in the axilla and inguinal. Okay, that's very suggestive for lymphoma. Okay, then you have to then that is the condition they will take over ASAP. Okay, then for the hyperviscosity syndrome, again, just now, okay, the same thing. So you can have either the polycythemia, leukocytosis, thrombocytosis, or in a patient that with multiple myeloma, you might notice there is a increased globulin. Okay, so this can lead to the hyperviscosity syndrome. So we go to acute leukemia. Usually they will present with anemia and thrombocytopenia, and there will be a leukocytosis, and you will find a blast cell in the peripheral blood. That will be very easy to recognize. Okay, you saw something that is abnormal. Okay, big cell. Then you know that it's abnormal, then it's very likely to be the blast cell. Okay. So for the SAA and the ITP, okay, to diagnose as severe aplastic anemia, the official criteria will be this using the ANC, platelet count, and the reticulocyte count. However, in the periphery hospital, you might not have the reticulocyte count and even the neutrophil, the differential count. So I would suggest you look at this. So the total one, if it's less than 1, okay, less than 1, the hemoglobin is less than 8, and the peripheral blood film, there's no abnormal cell, that will be sufficient enough to make you suspect SAA. Then for the ITP, the thrombocytopenia is usually less than 20. Okay. So for the non-hemato case that present to you, usually they won't. Because if they are diagnosed, usually we will institute preventive measures already, like for example, to prevent tumor lysis syndrome, that we will give the patient adequate hydration or advanced hydration and put the patient on allopurinol prophylaxis, and to make sure the patient don't go into septic shock after the chemotherapy due to the neutropenic fever, especially for the patient that with lymphoma treatment. Then we will routinely give a granulocyte colony stimulating factor to reduce markedly the chance of this. Okay. However, there were still cases that come to you. Okay, the possible scenarios that I can think of would be like the thrombosis, but it will be uncommon unless the patient is non-compliant to treatment. The patient that bleeding, the chronic ITP that suddenly relapse due to like viral infection. Okay, so suddenly have severe thrombocytopenia, then go into bleeding. And the patient that with MDS. Okay, so all the patient with unusually go into septic shock for the leukemia, lymphoma, myeloma, post-chemotherapy. But again, this is not so common if preventive measures are in place. Okay, so after recognizing the hematological cases, so your duty will be to keep them alive and stable until passing over. Okay, that's for sure. So I will put some, I will not be mention very specific things because I think it is difficult for you all to memorize specific things. I will put down some universal that will apply to every hematological patients. Okay, so of course when the patient admitted, and when you see the patient will need the IV line, but the one that you need to remember is not to put the IV line at upper limb, only put at lower limbs if the patient is SBCO. Okay, so and better if the patient and it's better to have a central line in cases with shock and thrombosis, and you think the patient will be under your care for a few days or at least certain period of time before passing over or the hemato take over. In resource constraint setting, I feel that the central line, the site would be better to be femoral instead of jugular, because femoral is easier to insert and less complication and easier to compress in case there is a bleeding. Okay, then for the IV drip, okay, routinely normal saline, but please remember something here in general, not to give normal saline in the patient that with SBCO, or only a very little, maybe 1 pint kit line open in SVCO, but you need to give more in the patient that with hyperviscosity syndrome, and a lot in the patient that present with hypercalcemia. So monitoring vital sign. So you will ask the nurse to monitor the vital signs for you. But however, for hematological patient, if you unsure, because if you did not order specifically, the nurse will monitor the vital sign every 4 hourly. That's the routine. Okay. But if you're not sure how frequent, you just and you worry the patient might turn critical suddenly, then you just order 4 hourly times 4 first. Okay, so that's the trick. Okay, then if you need to monitor the patient with blood tests, if you're not sure how frequent you should monitor, okay, and you're too scared to ask the hematologist, if you're not sure, just do daily. Okay, and because slightly over monitoring is better than under monitoring in hematological patient. Okay, then if the patient have white blood cell low, if the total white cell is less than 2, and if you don't have the machine that to calculate the neutrophil count for you in your hospital, okay, so you put the patient in the isolation room and you have a very, very low threshold. Let's say the patient there's no fever, no sign of infection, but if the patient had slight sign of infection after the admission, you please be having a low threshold to start the antibiotic, and the antibiotic that you use will not be the usual antibiotic. If possible, it will be something like tazocine, cefepime, or if the patient is in shock, you straight away go to carbapenem group. And if you notice the dose is very high, not the same dose like the usual infection. It is the dose for neutropenia. Okay, so but if you don't have this fancy if you don't have this more high-end antibiotic, a simple antibiotic like even ampicillin, augmentin is better than no antibiotic. Okay, and if you put the patient in isolation room, but the nurse can only go into the room every 4 hourly, it's better to put near the nursing counter than put the patient in the isolation room. Close monitoring is more important than isolation. Okay, and if the patient come with the HbA low, less than 10, try to top it out to about 10, and then at the same time, keep a group screen and hold 2 pine fat cell in reserve in case the patient go into bleeding or go into shock later. Okay, and if you have platelet in the hospital, platelet supply in the hospital, you try to keep the platelet more than 30. Please remember, this is very, very important. Platelet transfusion is contraindicated in TTP unless there is an ongoing life-threatening bleed. Because if a patient with TTP, if the patient does not have this life-threatening bleed, you transfuse the platelet just because your platelet is low, you are going to cause thrombotic event. Okay, the patient can collapse in front of you. Okay, another few more points to remark on will be the platelet from the transfusion does not sustain long. Okay, usually once you transfuse, the transfused platelet will survive in patient less than 5 days. Okay, so if you think you transfuse one time can sustain for 5 days, you only check the full blood count in 5 days time before you decide to transfuse again. No, don't. It will not sustain long. Usually in a patient that is very sick, it's usually only the most, especially if the patient got fever, it only sustain roughly about like the best 2 days only. Okay, so you need to monitor more closely. Okay, so and if the patient if you check the coagulation profile and found the patient, if the patient had bleeding and you check the coagulation profile and you found the ratio to be more 1.5 or more, okay, you transfuse FFP. But please remember, FFP is contraindicated in IgA deficiency. IgA deficiency, but you cannot diagnose IgA deficiency usually, but you can But if the patient develop any reaction during the therapy, you be very careful. But luckily, IgA deficiency is very rare. Okay. I specifically mentioned here, I think for those of you in district hospital, a specific management that worth learning, okay, is venesection. Venesection is actually the same like blood donation, okay? So if you got no one, there's no scientific officer or MLT who can do the can do the venesection for you, the blood bank staff that can do the venesection for you, in order to save the patient that with very high hemoglobin, and the patient present with like stroke, or you very worried the patient with is going into the stroke, despite the hydration, and the patient still having severe headache, giddiness, or CNS symptoms. You have to really think of, you perform the venesection for the patient before, if the hematology cannot take over the patient that soon. It will be really life-saving. You will really save the patient's life. How to do the venesection? So each time, each session of the venesection, it really take up roughly about like 450 ml of blood from the patient actually. So it actually means that you bleed the patient. Okay, how to bleed the patient? If you got the central line, that will be easier. Okay, you use the central line. You sit there, okay, which I did before, just like pleural effusion, a patient that with a lot of pleural effusion. So you put the line, you put a line there, you draw, then you withdraw, then you push the pleural fluid into the bag, the urine bag, the urine bag, or the the IVD bag. Okay, so you can do the same thing for the venesection if the patient got central line. So you put a three-way catheter, you draw slow, not to quickly 10 ml. So you slowly you draw slowly. Then you turn the three-way catheter, then to push the blood into a collection bag, then draw again, draw, then watch the patient, talk to the patient in case you too rapidly withdraw and the patient is having symptoms, things like that. If you don't have the central line, then you do like the blood donation. You put a BP cuff, then you inflate the BP cuff to roughly about like 40 to 60 millimeter mercury. So then you put a granular, bigger bowl granular, and you attach to a collection bag. Then you let it drain. Let the blood drain, like Dracula. Okay, you let it drain, but make sure you don't drain too fast. That's why you have to keep the BP cuff at roughly about like 40 to 60. The higher you put the pressure on, the more discomfort will be the patient. So usually you try to keep around like 40, 50. That will be enough already. Okay. Nowadays, if you don't have the manual BP cuff, the BP cuff that I'm talking about is the manual one. Okay, so if you really don't have the manual BP cuff, then you use the usual tourniquet during the blood taking, then to do the procedure. Okay, so this will be another information that I think is important for you all in district hospital, because a lot of time that you will have restricted resources. So this will be the blood group of the patient. Let me see, did I overshoot? Okay, I have not. Okay, so this will be the choice of the blood group, blood product, the grouping of the blood product for the patient with the following blood group. I think this will be quite, I think everyone will know about for Excel. So it will be better to be group specific, okay, and after group cross match. Okay, so but if you unknown and it's very urgent, the patient is in shock, use group O. For FFP, if you really got FFP in the peripheral hospital, if the patient present urgently and like in motor vehicle accident, although that is not hematological case, motor vehicle accident, then you want to quickly transfuse the patient, okay, like for the FFP, okay, then if you are non, then your choice is AB group, okay, but if you got the other, if you know the patient's blood group, that will be the choice of the FFP group in descending order. First choice will be O followed by this disease. Okay, so then for the platelet is a little bit because for PEG cell and LFP, it is very clear cut. So PEG cell, you look at the red blood cell blood group. FFP, you look at the natural occurring antibody in the plasma to choose the best option of the blood product. Platelets is a little bit difficult because platelet got the problem of both PEG cell and FFP. If you only choose according to the FFP, okay, according to the blood group, according to the FFP, you will make the platelet product less sustainable. That means that the platelet that you transfuse to the patient will live shorter in the recipient's body because platelet itself has the group ABO antigen on the platelet surface. So if possible, you have to go according to the group specific. Otherwise, if you are desperate, then you go according to the order, the order here, by choosing what do you want to preserve. You want to keep the platelet live longer in the patient, or you want to make sure the patient hemolyze less after the transfusion, or I think the most important choice, which one you want to choose, is the ability of your hospital to measure whether the blood product has a low titer NDA or NDB or not. If you got no facility to check that titer, you use the list over here. Okay, so okay, next, okay, another group of patients that will come to you all in district hospital. The one that very sadly is the non-hematological case on palliative care. We can't cure everyone, so there will be some acute leukemia patient or lymphoma patient or other diseases patient that we have tried, but they will not respond to the treatment, and we have to put them on palliative care. When they are on palliative care, the best is not to come to the hematology center that is far away from them, and the best person to care for them will be actually you all. You all are very important group of people to take care of this group of hematological patient. So when this group of patients come to you, just be empathy and tender loving care and pain relief. But honestly speaking, usually the hematology patient, unlike the patient that with end-stage lung cancer or GI or breast cancer, usually they don't have much pain actually. You will just see them wasted away, or they will just pass away due to acute bleeding episode or infection. But if they do come to you, so that will be what you want to provide the patient, and you don't have to give a high-fi management. So even the oxygen supplement will be an option. That will be your communication and your assessment on the patient and their family members' expectation on the oxygen supplement, whether need or not. The transfusion also best to avoid, because you can't do that forever. Okay. Okay, and then it's not recommended to give IV drip, transfusion or LFP or antibiotic. Okay. So that would be for the palliative care. Okay, and then that will be my last slide. Thank you for listening. I welcome any question. So if any one of you would like to open your mic and ask the question directly. If not, then I will look at the chat box to look for any questions. Okay. So, okay. So I have a question from Rebecca. May I know for a stable asymptomatic patient with leukocytosis, the total white cell of 30 plus, and thrombocytosis with a platelet of 800 plus, and PBF suggestive of MPN, but the patient refused further workup stroke referral, asymptomatic otherwise. Is there anything that we could offer or monitor from district or PD? Will aspirin help to reduce the disease burden, platelet, and reduce the risk of hyperviscosity? Okay. First of all, why the patient refused further workup or referral? Is it because of transport problem, or is it because they're scared of chemotherapy? You must remember to tell them the workout is very simple. If they do not want the bone marrow, we can always try to avoid bone marrow. But of course, in a younger patient, usually we will advocate bone marrow because it will help the management for a long run, or any kind of misconception about the management in hematology. So try to alleviate their fear. For this kind of patient, we will not give chemotherapy. They will not have hair loss or things like that. So try to find out why they refuse. And then try to alleviate their fear. So then if they still refuse, yes, definitely. The aspirin, if there's no contraindication from for example, gastritis or allergy, yes, the aspirin will help to reduce the risk of thrombosis, but it will not reduce the disease burden. Okay, it will not reduce the risk of hyperviscosity. Okay, it will reduce the risk of thrombotic event. If the disease progress, even though you put the patient on aspirin, the patient can still go to hyperviscosity syndrome. And worse, if the patient go into hyperviscosity syndrome, the aspirin actually can promote the occurrence of bleeding. Okay. Yes. So my answer is yes, aspirin can. Okay, can reduce the risk of thrombotic event. So the next question, do we need to do venesection for patients with secondary polycythemia? The answer is no. The answer is no. Because usually our management will target on treating the underlying cause that causing the secondary polycythemia. Okay. Okay. Why we cannot give normal saline in AVO? Oh, okay. Sorry. Maybe I give a misinformation because actually yes, you can give normal saline in AVO. My slide actually means that you don't give too much IV drip maintenance in SVCO. Maybe you put a granula there. You keep the line there, but without any IV drip order. If you want to give the IV drip, maybe just 1 pint normal saline, keep line pattern. Okay. Do every hematolist just now warrants PBF and bone marrow? I would say definitely warrant PBF. Bone marrow depends. Okay, Shelley. Shelley's answered. If a patient is being treated for neutropenic sepsis, started on the broad spectrum antibiotic, still having temperature spike, what should we do? Okay, so after you started the broad spectrum antibiotic, don't expect the patient to get better within a day, like the usual patient that usually present with pneumonia. No, they will not get better straight away within a day, but you will see improvement. If you see improvement, patient clinically is better, vital sign is better, patient is like happier, look more comfortable compared to yesterday, even though still got temperature, never mind, continue the same antibiotic because they will not get better until their total white cell count start to rise. Okay, so if they are still look well, getting better clinically, continue the same antibiotic. Okay, while you're waiting for the definitive blood culture to come back to decide on the further antibiotic. If the patient does not look better after a day, then you are even worsening. Then you escalate. You straight away escalate your antibiotic. Maybe if you are available, straight away to carbapenem. Okay, because the patient might have resistance bacteria. Hematology patient very easily get resistant bacteria. Okay. And we cut off hematocrit or HB for venous section. Yes, we try to for the patient who already diagnosed, we try to maintain the hematocrit 45 at below, because study had shown that that value of hematocrit will have the lowest risk of thrombotic event. But if a patient new case present to you, the hematocrit is sort of like, let's say 60. You cannot venosect until 45. Cannot. You have to go a bit slower. Okay, maybe today you venosect for 1 pint. Then tomorrow, see the condition, then you venosect again. Cannot straight away from 60 straight away go down to 45. The patient will die. Cannot. Okay. Okay. We can transfer back cell to patient under palliative care, but not FFP. Okay. So why we can transfuse back cell to patient under palliative care but not FFP or platelets, or give normal saline? Yes, you can give normal saline, because I said that KIV IV drip. Back cell, why KIV you can transfuse back cell is because once you transfuse, usually it can last the patient a bit longer, roughly about 1 month. But FFP and platelet, once you transfuse, it will, like platelet, it will last less than 5 days. FFP, okay, some of the factors, the very short half-life, within a day, the transfused platelet already used up, gone already. So that's why in a palliative care patient, we don't transfuse FFP or platelets, really, because it is, how to say, it is not practical. So for venous section, what is the value of hemoglobin? For the venous section is when the patient present to you with hyperviscosity. Okay, you suspect the patient with hyperviscosity. How frequent can the venous section be done? Okay, usually you can do it daily. Or if the patient can tolerate, you can venosect 2 times per day. That's maximum. But usually we just venosect 1 time per day. Okay. Sorry, chairperson, did I exceed the time?
I think it's all right. I think it's okay.
Can continue, huh? Okay.
Okay. Just maybe another. You have how many more questions to go?
Macam 2 more.
2 more. Okay. All right. We'll let you finish that.
Okay. So on the first question on the MPN, how about the role of hydroxyurea? Yeah. However, okay, you are talking about the first scenario just now, whereby the patient refused referral, and then referral to hematology, and the patient just want to be treated under district hospital. So you are asking, can you give hydroxyurea? If hydroxyurea is available, yes, I think you can, but be very careful. Because if you overdose, then the patient can go to cytopenia. Because hydroxyurea actually is a kind of mild chemotherapy. So you make sure you don't overdose. Okay. And If you are a physician, I think it's okay. If you know how to use the hydroxyurea, it's okay. But if you are a medical officer, please make sure you are really confident in using hydroxyurea before you start, because I feel you might get into trouble, some sort of like legal trouble, if the family members being difficult to you. Okay, sometimes we want to help patient as best as we can, but at the same time, you must remember, you must protect yourself. Yeah. Okay. Okay. The last question pertaining to my earlier question for neutropenia, sepsis, and temperature spike. Any role of PCM? Definitely. These how to say, symptomatic relief like PCM. Okay, definitely. Please go ahead. No problem. So, okay, I have another question. Link, is it okay? I answer another question.
One more to go. All right.
Okay. So I have a patient with PRV on hydroxyurea, refused hematome follow-up. Full blood count had been normal for the past 1 year. Can we just continue hydroxyurea long term? Is there anything that we need to watch out? Yes, you have. Okay, so first, Chen, I assume this patient is elderly. Okay, I assume this patient is elderly, because if this patient is younger patient, how young you consider young? It will be 45 and below, or less than 50. Less than 50. If they are young, please every time try to persuade them to refer to hematology, to refer to hematology, because for such a young patient, they have roughly about 20 years ahead of them. Usually, if the disease does not transform into secondary myelofibrosis or transform into acute myeloid leukemia. So for a young patient like this, we would like the patient to follow up under hemato, because we want to watch out for the earliest sign of transformation. Then we can straight away start the patient on or on other medication, on other treatment. For example, interferon. For example, JAK2 inhibitor, ruxolitinib. Or we really want to work out for autologous transplant. If this patient is elderly and refuse hematome follow-up, okay, and on hydroxyurea for the and the full blood count has been normal for past 1 year, okay, I can understand. So, however, each time you try to ask them again, see whether they want to follow up. If not, what you can do in the peripheral hospital is, you don't follow up then yearly. This kind of patient, usually at least the follow-up will be every 4 to 6 monthly. Why you need to have that kind of monitoring is because the dosing of the hydroxyurea can change over the years when the patient with the aging. Okay, and as I said before, PRV can transform later at higher risk, actually, in a patient that are elderly. So transform to secondary myelofibrosis and sometimes even to acute myeloid leukemia. So you cannot see them too far. It's roughly about 3 to 6 months. If you really desperate, then 4 to 6 months like that. So that you need to adjust the hydroxyurea dosing accordingly. It's not uncommon that the patient, when they grow older, the dosing of the hydroxyurea has to reduce. So I hope I have answered all the questions.
Okay.
I think I will answer the next question in the chat box. So thank you everyone, and thank you Dr. Ling for chairing the session.